Good evening, Assalamu alaikum. We are so delighted tonight to have this educational program on very important subject about anticoagulation, especially in special circumstances, such as a high-risk patient or after PCI. I really appreciate the company Saja of sponsoring this educational program, and I hope all of us will benefit from it. It will be, as I mentioned, two major talks, and after the talk we'll have enough time for discussion. I'd like to encourage all of you to get your opinion and ask question or comment. As you all know, that atrial fibrillation is really a major health problem, and especially in elderly. And the older we get, the more likely to get the atrial fibrillation. It can be up to more than 10% on elderly patients, like in their 70s and 80s. And the problem in atrial fibrillation, as you all know, is not the heart itself. The complication from AFib, it may have some effect on the heart if the patient have a tachycardia, but the major catastrophic problems from atrial fibrillation is the thrombosis, especially if end up with in the head and causing stroke. So for those patients, of course, to decrease the chance of having the stroke or any other systemic embolization, anticoagulation has been used and have a really good result for a long time. For almost a century, we have been using warfarin, and recently, in the last decade or so, we have been using the DUAC or NUAC, and seem to be much more effective and much safer and much easier to use, with less worrying about the interaction with medication or food. And that will make the life much easier for patients with atrial fibrillation. Most of the time, the atrial fibrillation decision of anticoagulation is very easy. But now it becomes tricky when there is a worry about increased risk of bleed, especially in elderly. And for that reason, we have a top expert in the field, Dr. Adil Khalifa. Is a consultant electrophysiologist from Bahrain. He is really going to go over this very important topic about using anticoagulation in elderly, and not to worry about, or less worrying about potential bleed, because those group of patients probably the worst risk of having stroke. So we're going to learn from Dr. Adil tonight about this, how to deal with elderly patients who have atrial fibrillation, and hopefully that will give us some comfort of using a full dose as needed. Dr. Adil.
Thank you, Dr. Omar, for the nice introduction, and good evening, ladies and gentlemen, my esteemed colleagues. Allow me, first of all, I'm trying to share my slides to thank the organizers and Saja Medical for their kind invitation. It's indeed my great pleasure and honor to be here tonight. And as Dr. Omar mentioned, I will be talking about, can you see my slides?
Yes, we can see your slide. If you can just make it on the full screen, but we can see it, yes. And your voice is clear.
Very good. Okay, can you see it now?
That's perfect.
Yeah, perfect.
Super.
Yeah,
thank you so much.
Thank you very much. So as I was saying, that my task today is to talk about anticoagulation in the elderly. And I find that the topic is really intriguing, because everybody knows that we are not doing a great job in treating the elderly patient when it comes to stroke prevention in AF. And part of the issue, as we will see, is that our underestimation of their risk of a stroke and overestimation of the risk of bleeding. And that's why we tend to have fear from treating this or these high vulnerable group of patients. And before I delve into this presentation, I would like to share with you all my relative disclosures here. So first of all, we are talking about the elderly, and there is another term which is sort of comes in hand with the elderly, which is a frailty. So let us start with elderly. What is the definition of elderly? So in most developed world countries, they have accepted the chronological age of 65 as the definition of elderly or the older person. And this actually coincides with the age of retirement. However, in phase 3 clinical trials, they have a slightly different definition because in these clinical trials, older people are defined as those who belong to the age from 75 years or more. And the reason why they chose 75, because from clinical trials, 75 years of age, here, this is the age where the risk of stroke increases significantly compared to younger age group. So how about frailty? So is it the same? It is not the same. Frail patients are patients at risk of or with established poor physiological reserve. They are at risk of high risk of falls, depression, and dementia, and poor physical functioning. And keep in mind that elderly does not mean they are frail, and frail doesn't mean that they have to be old. However, most of the time, they are linked to each other. So if you look at the distribution and the percentage of individuals who are 65 years of age in the world, and I will start with our countries, you can see that approximately 4% of our population in the Arab world belong to the age of 65. Now, there are slight variation in the percentage, but it's more or less in that range. If you look at, for example, North America, like USA and Canada, you can see that the percentages are significantly higher. In US, the percentage of patients above the age of 65 is 18%, and in Canada is 20%. Similar percentages are found in Europe, like in UK and France. However, if you look at Asia and Japan, who is really known to have the highest percentages of elderly in population with a percentage of 30%. And again, if you look at the world population by age group, we can see that almost 12% of the world population, they fall in the age between 60 and 79. To a lesser extent, 2% they belong to the age group of 80 to 99, and less than 0.01%, they are like 100 years of age or older. So they are actually, so we are seeing really a good percentage of patients who are or fulfill the criteria of elderly, and we have to know how to manage this group of patients in our clinical practice. So when it comes to frailty, as I mentioned, frailty is a different sort of category of aging process, and this has to be assessed by a specific scale. And I found that the Canadian clinical frailty scale is the most scale used, and they classify the frailty into categories, like 9 categories, from the very fit, well, managing well, moving to the red zone of severely frail, very frail, and terminally ill. Obviously, the diagnosis of frailty has to be made by somebody who's really specialized in this area in collaboration with a geriatrician. So again, if we look at the phenotypic definition of frailty, is based on 3 or more of the following: unattended weight loss, exhaustion, weakness, slow gait speed, and low physical activity. Let me just remind you from the ATRIA study of roughly 17 or 18,000 patients with AF, we found that the prevalence of AF increases with increasing age from less than 1% in the general population to 4% in those who are 60 years of age or older, to 9% in the octogenarians and nonagenarians. Furthermore, it has been estimated that by 2050, 4.4 of the world population will be older than 80 years. Similarly, if we look at the proportion of a stroke attributable to AF, also it increases with age from 1.5% in those between the ages of 50 to 59 to almost 24% in the octogenarians. All of us know that AF is not a benign disease because it is associated with high morbidity and mortality. Based on the Framingham Heart Study, it has been shown that the 2-year age as adjusted incidence of a stroke is 5 times higher in patients with AF compared to those without atrial fibrillation. Furthermore, if we look at the mortality rate, we can see that the 30-day mortality and 1-year mortality is significantly higher in patients with AF compared to those without. Now, the age is crucial, and to emphasize the importance of age as a serious risk factors in the development of a stroke, if we can see that the scoring system of CHADS, age 75 or above received 2 points, emphasizing that age by itself in isolation of other risk factors is a serious condition affecting the rate of a stroke. Similarly, aging process can also increase the risk of bleeding based on the Hasbred score. If we look at the proportion of patients 75 years of age or older in phase 3 clinical trials, we can see, as shown in this slide, that they range from 31% in the Aristotle to 44% in the Rocket AF. And the total number of patients in phase 3 clinical trials will approximately 28,000. So these are really well represented in phase 3 clinical trials, and the data supporting the use of NOACs is robust and reliable. And as we will see today, I'm not going to talk about phase 3 clinical trials, but I will actually talk about subgroup analysis from the landmark trials. I agree that there are challenges in the anticoagulation of the elderly, and this is related to many factors. One of them, the presence of comorbidities. As we get older, the chances of having renal impairment, hepatic impairment will be high. The risk of cancer also will be higher. And these comorbidities might interfere with many variables, including increasing the risk of bleeding. In addition, some of the medication used in the elderly might really interfere with the oral anticoagulation. And this is what we call the polypharmacy. So as we get older, more risk factors, patients take more medications, and the more medications patient takes, the higher the chances of drug-drug interaction, which again will make anticoagulation a bit challenging. Also, the risk of fall also increase as we get older, and this might also compromise our choice when we consider oral anticoagulation. The other factor, altered physiological function. Also, as we grow older, the percentage of body fat is increased relative to lean meat because we are losing weight. The amount of water in our body will be less, and this will interfere with the pharmacokinetics and pharmacodynamics. So the behavior of anticoagulation also will change in the elderly, and also this is a contributing factor in the challenge to start oral anticoagulation. Pharmacovigilance, frailty, compliance also are some issues that play an important role in our decision to anticoagulate these patients. This slide is taken from a retrospective study uh, by reviewing the medical records over a 4-year period in one of the leading academic centers in China. In this cohort, basically, they looked at specifically patients with AF initiated on oral anticoagulation, specifically with the age group of 80 and above. And these patients, they were stratified into 3 groups. Those who are between 80 to 85, 80 to 84, 85 to 89, and 90 and above. And also, if you can see the slide, these are divided into right and left. The right side of this slide represents patients with AF and a previous stroke, and the 3 graphs on the left side represent patients with AF but no previous stroke. And as you can clearly see from the yellow color, that we are not really doing good in initiating patients on oral anticoagulation, because the percentage of patients with AF above the age of 80 ranges from 12% to 25%. Now, more seriously, if you look at those at even higher risk, those with AF and had previous stroke, also you can see that the range of patients on oral anticoagulation only 14 to 26%. So this is clearly shows that we are not really treating patients appropriately, and we tend to underestimate the risk of subsequent stroke. Now, if we ask ourselves why we don't prescribe oral anticoagulation in the elderly or in those above the age of 80, and in this study, it has been shown that many physicians believe that the risk of hemorrhage, either current or past or recurrent, is high enough to make them not comfortable to start bleeding. So their estimation of hemorrhage will be much higher. And this is one of the reasons why they don't start oral anticoagulation. The second reason is their risk of fall, or at least their perception that the risk of fall in the elderly is so much high that we don't want to induce harm. So these are the 2 main reasons why we don't start oral anticoagulation. And this is reflected in the 2021 European Heart Rhythm Association guidelines for the elderly patients with AF, which they stated that oral anticoagulation remains underutilized in up to 30% of patients with high stroke risk. Older patients with AF have more favorable outcome on oral anticoagulation than without, and in NOAC than vitamin K antagonist. Furthermore, the 2020 European Society of Cardiology guidelines for the elderly have shown that we have evidence from randomized controlled trials and meta-analysis and large registries supporting the use of oral anticoagulation in this group of patients. So this is really in the guidelines, and the message was very clear. If we look at sub-analysis from the PREFER in AF study, and before we talk about the finding, just to remind you, what is the PREFER in AF study? So it's a registry involving 7,000 plus patients. This registry was carried out in 460 centers across 7 countries in Europe, where they enrolled consecutive patients with AF over a span of 1 year. And this meta-analysis or sub-analysis have shown that the risk of thromboembolic events increases significantly with increasing age, more than the increase in the bleeding risk. So our patients, they are at risk of thromboembolic events more than their risk of major bleeding. And again, if you look at one of my favorite studies, and it seems that this study became a reference when anyone talks about NOACs, this meta-analysis was published by Roth at the Lancet almost a decade ago, but still the findings are very interesting. So in this meta-analysis, the efficacy and safety of NOACs compared to warfarin, specifically in the elderly, was sought out. And as you can see, that overall, NOACs are associated with almost 19% relative risk reduction of stroke and systemic embolism. And the efficacy of NOACs in stroke and systemic embolism occurs regardless of the age, whether the patient is less than 75 or more than 75, and there is no interaction between age and the efficacy of NOACs in this particular efficacy outcome. If we look at major bleeding, we can see that both NOACs and warfarin, they had similar rates of bleeding when it comes to elderly population. Now, if we categorize age group, there is a significant reduction of major bleeding in those who are younger than 75. The relative risk reduction is roughly 21%, while those who are 75 years of age, there is a trend toward reduction in major bleeding in the elderly, but it was not statistically significant. So this slide gives us reassurance that the efficacy of stroke and systemic embolism in the elderly population is well maintained in NOACs, and they are more efficacious and similar rates to vitamin K antagonists. This is another meta-analysis comparing NOACs versus vitamin K antagonists in the elderly population, i.e. those who are 75 years of age or older. This meta-analysis included 32 studies, 27 observational studies, and 5 randomized controlled trials, included approximately 500,000 individuals. So this is really one of the largest studies. And if we look at the results, comparing the efficacy and safety of NOACs when it comes to stroke and systemic embolism, there is a parallel finding between observational studies and randomized clinical trials. So both of them shows that NOACs associated with significant reduction, almost 50% in the stroke and systemic embolism. Both types of studies, observational and RCTs, associated with significant reduction in intracranial hemorrhage. Both studies also have shown that there is a trend toward reduction in major bleeding, although it was not statistically significant. Now, the price is what the NOACs is paying because of this is the risk of GI bleeding was higher in NOACs compared to vitamin K antagonist. Now, if I draw your attention to the right side of this slide, if we look at the efficacy and safety of NOACs individually, looking at the following parameters. First, stroke and systemic embolism. All the NOACs associated with significant reduction in the risk of a stroke and systemic embolism. All the NOACs, with no exception, associated with significant reduction in intracranial hemorrhage. However, in the elderly and those who are 75 years of age, major bleeding was significantly and specifically reduced in the edoxaban group and apixaban group with more or less similar hazard ratio of between 0.52 and 0.57. When it comes to all-cause mortality, as shown in this slide, only edoxaban was associated with almost 27% relative risk reduction of all-cause mortality in the elderly population with AF. So again, these actually studies, these are large, robust trials, will confirm that the NOACs and specifically edoxaban is actually efficacious and safe in the elderly population. Let me actually go through a very interesting study called the Elder Care AF. This study randomized patients or elderly patients, 80 years and above. These patients deemed not suitable for conventional dosage of phase 3 clinical trials of NOACs. So these patients, they were randomized to either ultra low dose of edoxaban at 15 milligrams, and this is not the dose, not approved for obviously stroke, but in this study, it was given in this group of patients versus placebo. The study included 984 patients from Japan. And as I mentioned before, Japan has one of the highest percentage of elderly population. So in this elder care AF, you can see that in elderly, those who are 80 years of age and above, receiving ultra low dose of edoxaban at 15 milligrams once daily, associated with significant reduction in stroke and systemic embolism with not a significant increase in major bleeding. Now, as I mentioned before, this study applies to Japanese population. Now, whether we can replicate this study or we can make it generalizable to other group of patients is questionable, but at least we can have an alternative in the elderly of giving them a smaller dose of edoxaban at 50 milligrams once daily. Again, if we look at subgroup analysis from the ENGAGE AF TIMI 48, this is the phase 3 clinical trial of edoxaban. And in this subgroup analysis, patients, they were stratified into 3 groups. Those who are 65 years of age and younger, representing 26%. Those who are 65 to 74, representing 34%. And those who are 75 years of age and above, representing 40% of the entire study population. Now, also keep in mind, as you can see in the table on the right side, that 88% of patients above the age of 75, they belongs to the CHA2DS2-VASc score 4 to 9, and 56% they have Hasbro score of 3. So these are really high-risk group of patients. Now, as you can see here, that the risk of stroke and systemic embolism also increases with increasing age, but look at major bleed. Major bleed increase with increasing age to an extent more than the risk of stroke and ischemic stroke. And it seems that the graph diverge at the age of 75. So once the patient reach 75 or beyond, the 2 graph between a stroke and major bleed diverge. So 75 is the age where patients, they have higher risk of major bleeding. Now, despite this, look at the safety point of major bleeding in patients taking edoxaban. Clearly, you can see at all age group, there is reduction in major bleeding with edoxaban, starting from patients less than 65 years of age, where there is 20% reduction in major bleeding, moving to post hoc analysis in those who are 75 years and above, 80 years and above, and 85 years above. And you can see that the reduction in major bleeding is 42% in those who are 85 years of age and older. So despite their risk, as I mentioned before, that the risk of bleeding increases at the age of 75, it seems that edoxaban reduces the rate of major bleeding in this vulnerable group of patients. Furthermore, if we look at the primary net clinical outcome, which is essentially the composite of the primary efficacy and safety endpoint, you can see that those belonging to the group 75 years of age and above, they have a positive primary net clinical outcome. And again, if we look at other studies that looked at the safety of different NOACs in elderly population, you can see that edoxaban stand out in addition to apixaban as a agent that significantly reduce the rate of major bleeding. And again, the risk ratio more or less was the same between edoxaban and apixaban. And this had actually influenced the European Heart Rhythm Association in their guidelines to mention, and this is basically copied from the guidelines when it comes to patients frail and risk of fall based on the positive impact of edoxaban in this group of patients. It has been shown, and they wrote, this is in the guideline, and I will read it for you word by word, that the absolute risk reduction was greater with edoxaban in patients at increased risk of fall. And when it comes to patients with low body weight, both apixaban and edoxaban showed consistent efficacy and safety compared to warfarin in underweight patients when compared with the overall study population. Again, if we extract data only for those at risk of fall and low body weight, and you can see that the absolute risk reduction is better in those with increased risk of bleeding. So their hemorrhagic stroke was lower in those with increased risk of bleeding. The intracranial hemorrhage was less compared to those not at increased risk of fall. So fall might not be worrisome in elderly population because previous studies have shown that patients needs to fall almost one time per day over 1 year span to make oral anticoagulation contraindicated. But this is really reassuring that the absolute risk reduction is higher in patients at increased risk of fall. On the other hand, if we stratified the outcome by dose reduction criteria, comparing warfarin, high-dose edoxaban, and low-dose edoxaban in the efficacy outcome of stroke and major bleed, you can see that high-dose edoxaban associated with lower rates of stroke and systemic embolism and lower rate of major bleed, specifically in those who are 60 kilograms or less. So this is an add-on also reassuring data about the efficacy of edoxaban in the underweight. And I will actually end my presentation with this slide before going to the conclusion. And this is actually a very interesting study that looked at patient preference for NOACs in stroke prevention, which is like a multi-country discrete choice experiment involving 758 patients with a mean age of 72 years. This multi-country discrete choice experiment was carried out in France, Germany, and UK. Here, patients, they were asked to rate their experience with the following 3 questions. What is your preferred NOAC based on the frequency of administration? Do you like the once daily NOAC or the twice daily NOAC? And clearly, all patients, they chose the once daily NOAC. And we have only 2 drugs with a once daily NOAC, which is edoxaban and rivaroxaban. The second question is whether the size of the tablet or the capsule is important. And the NOAC comes in 2 sizes, the 6 to 9 millimeter tablet or capsule and a 20 millimeter tablet or capsule. And clearly, they chose the smaller size of tablet or capsule. And remember that elderly patients, they have sometimes difficulty in swallowing, and smaller size of tablet or capsule makes the swallowing as much easier. So obviously, these patients, they chose the smaller size of tablet and capsule, which is edoxaban, rivaroxaban, and apixaban. Finally, they were asked whether it does matter for them whether they can take it with meal or without meal. And obviously, they prefer not to restrict themselves to meal. So they wanted to be independent of food. And 3 drugs, they were independent of food, which is edoxaban, ebexiban, and dabigatran. Now, if you look at who scores in all of them, edoxaban scores in all the three choices in the frequency of administration and size of the tablet and meal. So their preferred drug based on this experiment is edoxaban. Now, surprisingly, the preference was edoxaban, despite the fact that the distance for patients to take the tablet was longer compared to the other drugs. So if the physician lives in a longer distance, this does not really matter for patients because they would like to have other features that help them to take. So this is actually another interesting fact about edoxaban. So my take-home message, Mr. Chairman, ladies and gentlemen, my esteemed colleagues, the number of people aged 65 years or older worldwide is projected to be more than double, rising from 761 million in 2021 to 1.6 billion in 2050. The number of people aged 80 years or older is growing even faster. The proportion of patients 75 years of age or older in phase 3 clinical trial ranges from 31 to 44%. Anticoagulation in the elderly is very challenging due to the presence of comorbidities, polypharmacy, risk of falls, altered physiological function leading to changes in the pharmacokinetics and pharmacodynamics of the drug, frailty, and compliance. And it seems that in real life, oral anticoagulation therapy is underutilized in the elderly at high risk of stroke due to underestimation of the risk of stroke and overestimation of the risk of bleeding. NOACs are both associated with better efficacy and lower major bleeding in elderly, and particularly ebexiban and edoxaban, based on European registry demonstrated excellent patient preference of edoxaban, and edoxaban has a robust data on the use in elderly with both efficacy and safety. And thank you very much.
Thank you so much, Dr. Adil, for this amazing presentation. You really get to the bottom of the whole worrying about this using anticoagulation in elderly. And as you mentioned, the elderly have much more risk of stroke comparing to younger. And you show in the earlier that between age of 60 to 70, the risk of stroke increased 3 times. It really jumped right in there. And from 70 to 80, increased another probably two times to 3 times. So
Yeah.
the older the patient get, the more likely to have a stroke. And as you said, is the age above 75, you got 2 points for that alone for the age. And so it's thank you for kind of reviewing this issue about anticoagulation in elderly, because this is what we kind of to deal with it every single day, to deal with the patient and family and concern about the bleeding of those elderly patients. We open the, I don't know if Dr. Asmat is available or not yet. Muhammad, is Dr. Hussein available or not there? Because he was running related from the airport. Anyway, so we'll go over a few questions from the audience until Dr. Hussein able to join us. And I don't know if you have any question from the audience, please let us know, and we'll have Dr. Adil here to help us answer all those questions. So it's kind of patient come in, elderly lady come in on CAN to your clinic with atrial fibrillation, and the family said, well, really anything make her bruise, and we worry about if you're going to give her a blood thinner, she's going to bleed a lot and so on. What do you tell the family? And how do you evaluate that patient first, that it's really she will be candidate for a full dose or lower dose or any dose?
So I think, this is a very nice practical question that we deal with it on daily basis. And I feel sometimes that relatives are testing us when they say that, my mother or father bruise easily. And this might actually add pressure on us. If a patient is bruising, then we tend mentally to overestimate the risk of bleeding, which is not really real. Uh, if I compare the risk of stroke and compare it to slight bruising in the skin, this is not justification to withhold anticoagulation of these patients. How do I assess them? Well, the assessment is clearly based on the CHAD VASC score and the Hasbro score. This is the first thing. Now, in the presence of other variables, like if there is evidence of frailty, or if I feel that genuinely the patient is at risk of a stroke, or risk of fall, or he has early dementia, or etc., then probably I will refer him for a geriatrician for further assessment, and based on that, we work together. So sometimes the decision of anticoagulation is not made in isolation. It's a multidisciplinary team. But overall, most of the time, I can make the decision by myself. And I have several patients who are 80 years and above on full dose, NOAC, with no complication. As long as I assess their kidney function, I adjust their dose based on the kidney function, based on weight, based on bleeding risk, etc., then you will be fine.
Great. Just kind of remind us again about the things that you take in consideration for adjustment for creatinine. What is the creatinine clearance you adjust the dosage?
So basically, we have a different dosage for different NOACs. So remember that for example, in rivaroxaban is purely based on creatinine clearance, which
Yeah.
is like,
Kidney.
yeah,
Kidney
kidney function.
clearance.
Exactly. Other NOACs, weight is important. Like, for example, apixaban, you have to
Right.
consider also weight less than 60, age more than
Sure.
85, then creatinine, etc. So with edoxaban, it is 30 and 60. You have two dosages. And again, based on the weight less than 60 and based on the creatinine clearance, you decide, if the presence of one or more of these factors, you would reduce the dose to 30. In the clinical trial also, they've mentioned that if a patient is taking drugs with a strong BGB inhibitor, you would actually also reduce the dose to 30.
So, I mean, just to clear, it's for if the patient have creatinine clearance less than 25, 30, what number you use
Yeah,
to
yeah.
yeah.
So basically,
Mm.
the I mean, all the NOACs not studied in patients with creatinine clearance less than 30. So all of them. However, we have some data to support the fact that, from 15 and above, you can use the smaller dose. So, for example, a creatinine clearance of 25, I would use the 30 milligrams.
Okay. Okay. Now I have a question. Loading dose with DOAC or bridging needed for initiation or not?
Um,
First, when you start first, do you need to load or just start with a maintenance dose, one
yeah,
tablet a day?
Yeah, so I mean, the interesting thing about NOACs is that they are rapidly acting. So on average, all of them, they will start working within 2 hours. So they don't need really bridging with any type of anticoagulation. So you can just give them straight.
Exactly. So that's a little bit different than patient with DVT. They have to have different protocol. But for atrial fibrillation, you just
Correct,
start first dose is the
correct.
same as daily dose.
Correct.
Great. Now, I think you mentioned there's a question about relation of medication of the using DUAC with food. You mentioned earlier that different DUAC have different relation to food, and just can you tell us again about the four DUACs and the food? Is it
Yeah.
related to food or
Yeah.
not?
So all the three NOACs, namely Megatran, Epexiban, and Edoxiban, uh, they don't really matter whether you take them with food or not. The exception is Rivaroxaban, because the bioavailability of Rivaroxaban is roughly 60%. And if you take it with food, you increase the bioavailability to 95 to 100%. That is why it is a must. It's a must for rivaroxaban to be taken with food. And this is not an issue with other NOAC.
Super. Question: we have a patient with on DOAC planning for small intervention or outpatient therapy and like dental extraction. What's your recommendation?
So again, the recommendation is based on the guidelines, and for a single tooth extraction, there is no need to stop any of the NOACs. And this is because this is a minor procedure. We run
Right.
in real life, we always run into an issue with the dentist. They don't feel really comfortable extracting, the tooth uh, on NOAC. If this is the case, we tell them to do it at the trough of the medication and not at the peak.
Okay. How about cardiac catheterization?
Cardiac catheterization, again, you can use the NOAC, you can use the radial access, and it depends if you anticipate you would give the patient intravenous heparin or 2B3A, depending on your possibility of underlying CAD, then probably you can stop NOACs. But I will leave that to Dr. Hashmet. He will
How
talk
about
about
how
PCI.
about yeah, of course. How about colonoscopy or endoscopy?
So again, there is no right or wrong answer. We always speak with the gastroenterologists. If they are suspecting that
Biopsy.
there is a biopsy, etc., we tend to stop it one day, or they can do it at the trough and not at the peak. And this should be enough.
Excellent. Excellent. And now a question about patient overweight, about 120 kilogram. Do you have to adjust the dose or the same dose?
This is really a very big topic. And I don't recall that many patients were included in phase 3 clinical trial belonging to that age group. But, the issue with weight is that as patients are obese, the creatinine clearance will be increased. So there is always a risk of NOAC washout. So they don't actually receive the appropriate dose of NOACs. But overall, if you look at the body mass index, up to 40, then there is no issue. It's not like an absolute weight. We will go with the BMI. So if the BMI is 40 or up to 40, then we have evidence that the NOACs will work. Between 40 and 50, it's individualized. But above 50, and I'm talking about BMI, we don't have evidence. So either you have two options. Either you check the plasma levels of the NOACs and adjust the dose based on plasma levels, or you can just go to the warfarin.
Great. Now, a question here. Somebody said, why prefer apixaban 2.5 twice a day rather than 5 in elderly patients?
So this is based on practice, not based on science. And as I mentioned, in the Aristotle, it was very clear in phase 3 clinical trial. You have 3 criteria. If you fulfill the criteria, you can give 2.5. Age more than 80, weight less than 60, and creatinine of 133. If you have
Yeah,
2
2 out of 3.
Yes, 2 out of 3. Beyond that, if a patient only 85, for example, he has no other parameters for weight for dose reduction, then I will give them 5. So this is part
Super.
of the misconception about Ebexiban.
Well, yeah. DUAC antidote.
So so basically there are two antidotes. One of them is idurosizumab, which basically antagonizes the effect of dabigatran, and I used it myself several years ago. And there is the other one for factor 10 inhibitor. I forget the name of it. We don't have it here. I don't know if you have it in UAE, but I don't have any experience in using it. And honestly speaking, I've been using the NOACs for nearly a decade or more. And we used idurosizumab once or twice in the last 10 years. We don't really need them, that frequently.
Okay, great. Now, issue of which patient you will say, well, probably it's better to go for left atrial occluder than using the DUAC.
So again, this is an individualized approach. If the risk of a bleeding is very high, somebody
Like somebody has recently I bleed, or yeah.
like even spontaneous brain hemorrhage for no good reason, then it's quite risky to start them on NOAC. So this is probably one of the criteria where you would use left atrial appendage closure. Those with malignancy and their risk of bleeding on oral anticoagulation is very high, I might consider also appendage closure.
Yeah, I guess we have one more question, and then we'll go for Dr. Hussein, one or two questions. Now, a question is comparing to warfarin. Are they superior to warfarin or equal to warfarin for the efficacy? And second thing is, are they equal or superior in bleeding risk? Can you just give a quick summary on that one, please?
Yes. So just to summarize, and again, I mean, to answer this question, I have to say some trials, but I realize that maybe time is short. Yeah, they are definitely superior when it comes to stroke and systemic embolism, and they are non-inferior or equal when it comes to major bleeding, and they are superior when it comes to intracranial or intracerebral hemorrhage.
So all of them, they are superior for intracranial hemorrhage.
Yes.
But not all of them are superior to warfarin for preventing stroke, right?
Yeah. So this is
they are equal. They're basically equal to warfarin or superior than warfarin for preventing stroke.
Yeah. So again, my answer was a general one. If you want me to talk about each individual, because when I show you the rough meta-analysis, all of them are superior to as a group. But if you look at the individual NOACs, for example, dabigatran 150 was superior to warfarin. If you look at rivaroxaban, it was non-inferior. But if you look at all the NOACs as a group, they are superior, and I showed that in the meta-analysis. They are superior when it comes to stroke and systemic embolism as a group.
Okay, great.
Yeah,
great. Now for reversing the dabigatran, for example, you use one dose or more than one dose?
Usually, and again, if I remember the dose correctly, and forgive me if I made a mistake, but I think
okay. No, that's the dose, doesn't matter. But I mean, like one dose or more than one dose.
It's actually usually it's 2 dosages separated by 10 to 15 minutes. So you give the first dose, and if you need additional reversal, you give the second dose. As I mentioned, I used it twice before, and I used always 2 dosages.
So a patient have DVT and despite being on DUAC, what do you do?
So this is a different talk. Yeah. So this is a different talk about DVT.
Let's see if a patient have have a stroke in spite of being on DUAC. What do you do?
I mean, again, we have this is again a big topic. First of all, we have to know whether the patient is compliant, whether the patient is taking the right dose for him based on kidney function. As you mentioned, sometimes we give patients apixaban 2.5 PD for no good reason. So we would like to make sure that they are taking the right dose of NOACs based on their weight, their kidney function. But beyond that, if we are sure that the patient has a stroke on one NOAC, I can shift him to the other NOAC, or I can go with warfarin. So you have multiple options.
Great. Well, I cannot thank you enough, Dr. Adil, for a great presentation and a great answer. I wish we have a little bit more time, but if we have some time in the end, we'll get you back again. Now, we were waiting for Dr. Hussein, and Alhamdulillah Salam, Dr. Hussein. He just arrived. You are muted, Dr. Hussein. Can you unmute yourself, please?
Yes, sir.
Yeah.
Sorry.
الحمد لله على السلامة.
الله يسلمك.
نورتنا
Thank
حياكم
you.
الله.
Thank you,
أهلا
Dr.
وسهلا ومرحبا. It's thank you, Dr. Adel, and now great welcome to Dr. Hussein for his being able to join us, and Dr. Hussein Hishmat. Dr. Hussein Hishmat is a professor of cardiology and consultant interventional cardiologist. And he's going to talk about a very interesting subject. We have a lot of kind of worrying about, especially in the beginning, because we were not sure what to do if the patient have atrial fibrillation, being on DOAC, and need to go for PCI, or vice versa. Patient have PCI, and then you have to put him on he got develop atrial fibrillation, and you have to put him on and for DOAC. This is very interesting subject and very important and very relevant, and we are delighted to have Dr. Hussein to tell us about it. Dr. Hussein, all yours.
Thank you, Dr. Omar, for the kind introduction, and it's my pleasure and honor to be with you again, and it's my pleasure to be speaking after Dr. Adel, a wonderful and knowledgeable speaker. So I will be delving into a very complex topic that has lots of iterations, which is atrial fibrillation and a patient undergoing PCI. So I will start with a case vignette, which was a real gentleman that I've been treating in April of this year. He's an 83-year-old British gentleman. He's retired, and he recently traveled to Dubai with his daughter and family who live here in Dubai. He comes back from the UK with a long history of hypertension, tuberculosis, chronic obstructive pulmonary disease, heart failure with preserved ejection fraction, prostate cancer, just to name a few. He presents to the hospital emergency with acute onset of dyspnea, chest pain, and rapid palpitation. And because he's an attentive gentleman, he's still leading an active life. He knows exactly when the entire symptoms started. It was just 1 day ago. On presentation, his blood pressure was 86 with a past history of hypertension. He had atrial fibrillation at a rapid rate, and he was in severe respiratory distress in acute pulmonary edema. And on examination, in addition to the coarse crackles, we couldn't find any pedal pulsations on both sides. And that's his ECG on presentation. You can see the atrial fibrillation with a relatively rapid response. You see some ventricular ectopics and downsloping ST depression in the lateral leads and in the inferior leads. In addition, he had rising inflammatory markers. His eGFR was 45. His X-ray showed the old tuberculosis and right lower lobe pneumonia. We started broad spectrum antibiotics. We gave him fluids. His ejection fraction was 45 to 50. And we tried to revert the atrial fibrillation with intravenous amiodarone, which failed, just got him hypotensive. So we had to cardivert him electrically. And because of marked elevation of troponin and chest pain, we had to take him to the cath lab. Then we had to think which anticoagulation for an ACS with atrial fibrillation. So before cath lab, it's low molecular weight heparin, full dose. Sometimes we like to give the first part of the first dose in an intravenous injection. And of course, we give him aspirin. We stopped pre-treating patients with non-ST ACS with the second P2Y12 inhibitor because it's not effective and is associated with more bleeding. And this is what we found on angiography. We had this lesion in the proximal LAD, and we had to treat that with a stent. And we chose to use the biofreedom stent because we can stop antiplatelets earlier. So this is the IVUS picture pre. We see the tight lesion with some calcium, and this is after the stent. When we encounter these patients, we need to think of bleeding. So we went for radial access, a stent that we can stop the dual antiplatelet in a month, and we go for IVUS. Then the question is, how would you anticoagulate such patient with ACS, atrial fibrillation, who just had a stent? And I'll give you the guidelines, and this is what we did. Aspirin planned for just 1 week, clopidogrel during the PCI without loading because he's above 75. We planned that for 1 month. And then edoxaban 30 milligrams once daily, and that's planned indefinitely. Why? Because he has atrial fibrillation. Obviously, his SHAD-VASc score is high because of hypertension, congestive heart failure, age more than 75, vascular disease. So it's probably 4 or 5. In addition, the Has-Bled score is also high. So his atrial fibrillation on its own is complicated, and it gets worse because of the PCI. We know from our practice and from the literature that 1/3 of AFib patients have coronary disease. 10% of patients who go for PCI have concomitant atrial fibrillation. And we know that PCI on its own is associated with a high risk of embolization stroke, especially in hypertensive patients, patients on an intra-aortic balloon pump, history of stroke and thrombus aspiration. And on the other hand, we know that bleeding after PCI is associated with a significant increase in in-hospital mortality. Regardless, was an axis bleeding, a GI bleeding, an intracranial hemorrhage, the mere presence of bleeding in the hospital results in 3 times higher risk of mortality. So bleeding is not just some blood loss that we can correct with transfusion. Bleeding after PCI means mortality. So we need a dual antiplatelet for the stent and for ACI and for ACS, and we need an anticoagulant for the atrial fibrillation. And of course, we know that as we add more medications, then the chances of bleeding become higher and higher. And if we look at this very particular patient, he has both predictors of thrombosis and predictors of bleeding. Looking at his age, looking at his peripheral arterial disease, looking at chronic kidney disease, at heart failure, this makes him more likely to thrombose. And looking for the need of anticoagulation and drug interaction, that makes him also a higher bleeding risk. So how did we start getting out of this dilemma? In the early days, before NOACs became widely available, we had just warfarin. And we had a big trial, which is the VOICED trial, and then other small trials. And when we look at a meta-analysis of like 13 or 15 trials, more than 7,000 patients, we find that comparing triple therapy with vitamin K antagonist, clopidogrel, and aspirin to dual therapy is associated with less bleeding, even with a vitamin K antagonist, even with warfarin, and the same incidence of death, MI, or stroke. But because warfarin is getting forgotten from medicine, we had to think of getting NOACs in the game. And this is the latest European Society of Cardiology guidelines on anticoagulation in patients who have an ACS and an indication for anticoagulation. We go for triple therapy for roughly 1 week, and that's what we plan. After 1 week, we'll get rid of aspirin. Then we will continue on a NOAC plus a single antiplatelet in ACS, ideally up to 6 months. But in high bleeding risk patients, we can abridge that to 1 month, like in our gentleman. Then we will continue a NOAC monotherapy starting on indefinitely. So which NOAC would fit better, would fit best like this gentleman that I just presented? If we look into the 4 trials of NOACs in PCI, every NOAC has its trial, and they're all relatively big trials, thousands of patients. But which one would fit the PCI more? In my humble opinion, I would go for either dabigatran or for edoxaban. Why is that? Because the trials of dabigatran was probably the only trial that looked into two approved doses for atrial fibrillation, and they were randomized. So they tested the 150 and the 110 dose. But looking at the rivaroxaban with Pioneer, the dose that they used is not a dose for atrial fibrillation. It's a dose for peripheral arterial disease. And even the 15 milligram dose is not the recommended dose for stroke prevention. So there are some doubts if you look at the trial of rivaroxaban. When we look at the trial of apixaban, they got a big number of patients, but the duration of follow-up was rather short. Compare that to the edoxaban trial with PCI. They followed for 12 months, and for the dabigatran, they were followed for 30 months. Again, patients in the trial had different baseline features. If we look at the trial of edoxaban, a higher proportion of acute coronary syndrome, a higher proportion of prior use of oral anticoagulation, and patients were enrolled within 4 hours after the sheath removal, unlike dabigatran 72 hours, or rivaroxaban 120 hours, or with apixaban within two weeks of the index event. So patients were not randomized after the sheath removal. So the trial of edoxaban is more representative of real life. So what they did, they randomized patients into edoxaban 60, and the dose could be reduced to 30, like in our patient, if the eGFR is less than 50 or the body weight less than 60. And that's a dual therapy after a short period of aspirin, or to vitamin K antagonist plus P2Y12 inhibitor plus aspirin. And aspirin was guided by the clinical presentation, ACS or stable coronary artery disease, and the duration varied from 1 to 12 months. They looked at the primary endpoint of International Society of Thrombosis major or clinically relevant non-major bleeding. What did they find? That edoxaban, if we look at the end of the first year, edoxaban was associated with a visible reduction in the primary endpoint of major and clinically relevant non-major bleeding, with a 17% relative risk reduction. P-value for non-inferiority highly significant, but for p-value for superiority, it was not significant. And we'll look at the reason behind that. If we exclude the first 14 days of the analysis, then it becomes highly significant. So what does that mean? It means that in the first 2 weeks in this trial, warfarin did a great job. Why was that? We'll look into that later on. But if we divide patients into ACS cohort from the same trial and chronic coronary syndrome cohort, we see that the curves are starting to separate after 14 days, and the difference is clearly visible. We get roughly 36% reduction. We get rid of 1/3 of the bleedings with edoxaban. That was in an ACS, and also in chronic coronary syndromes, we get more or less the same reduction, 30%, and the curves start to separate after 14 days. So why did warfarin have a lower bleeding risk in this case? Probably because if we look at the first 14 days and those who were on warfarin, the majority of patients did not reach their target INR, so they were not properly protected, and that can explain why the bleeding was significantly lower in the first 2 weeks of warfarin. And by the way, this is a relatively common scenario in the NOAC trials. Even with the trial of apixaban, in the first 14 days, the curves were more or less the same, and they started to separate after 2 weeks. Keeping in mind that with apixaban, 26% in the trial did not undergo PCI, so it's not really reflective of the clinical practice in patients who get a stent. So if we compile all the trials of NOACs together, what do we conclude? There are some important conclusions. Number one, major bleeding and clinically relevant non-major bleeding are reduced when we look in NOACs in general compared to warfarin. All-cause mortality is the same, cardiovascular death is the same, but there is an important signal. It's not statistically significant, but you need to keep it in account, that myocardial infarction may be slightly higher with the dual therapy compared to the triple therapy, and there is a signal for increasing stent thrombosis with dual therapy compared to triple therapy. So what should that tell us? It should tell us that we need to individualize our treatment decisions. In patients with ACS, triple therapy can be extended between 1 week up to 1 month. In patients who you're worried about stent thrombosis, you can extend it to 1 month. If you're worried more about bleeding, then you can shorten that to 1 week. And this again is left to the art of medicine, not to solid indications. And how does that apply to patients with coronary disease or not having a stent or having an acute coronary syndrome? We know from the ENGAGE TIMI 48 trial that looked at patients with atrial fibrillation and where edoxaban was being tested. They found that, of course, edoxaban resulted in a bigger reduction in stroke and systemic embolism compared to warfarin. So we're looking here for some superiority. And the bleeding risk was significantly reduced with edoxaban, even in patients with coronary artery disease. And comparing all NOACs, it seems that edoxaban is the only NOAC that reduced the risk of stroke and systemic embolism and myocardial infarction in patients with coronary disease. If we look into the 4 trials of NOACs, that edoxaban 60 and 30 reduced stroke systemic embolism in coronary artery disease patients, had the best reduction in bleeding with apixaban, and had the best protection from myocardial infarction in patients with coronary artery disease. So what are the take-home messages here? Atrial fibrillation and PCI are notorious when they are combined. We need to balance, of course, the risk of thrombosis and bleeding, keeping in mind that bleeding is not just transfusion, bleeding means mortality. And in those individuals with high bleeding risk, you need to think of the stent platform, you need to think of intracoronary imaging, you need to think of short duration of dual antiplatelet therapy, and you need to choose a NOAC with a high record of safety and efficacy, and definitely edoxaban is one of them. Thank you so much.
Thank you so much, Dr. Hussein, for this amazing presentation. Thank you so much. It's a very difficult, complex problem, but we deal with it on a daily basis, and always there is kind of debate what to do. Now, let me ask a simple question. We have a patient on DUAC and have acute coronary syndrome, STEMI, for example. Going to take him straight to the cath lab, and he took a dose of DUAC a couple of hours before he came to STEMI. What do you do with that patient regarding anticoagulation? In the cath lab, or do you do anything different in the cath lab? He took his DUAC in a few hours just before his acute MI.
Yes, I would definitely take him to the cath lab, because the other option would be thrombolytic therapy, which we know is not the way to go, and it will be associated with major bleeding. I'll try to do it radial, and I would still give him some unfractionated heparin, making sure his ACT is between 250 and 300. And then after the procedure, we do not preload now. Even preloading in STEMI is a class 2B. So we start loading as we diagnose the culprit vessel and we engage in the PCI. And then after the procedure, I would continue NOAC with clopidogrel and aspirin, and I would not use any low molecular weight heparin after the procedure.
So during the procedure, do you use a full dose of heparin during the procedure?
Yes, I would go for unfractionated heparin. Yes.
Okay. Why unfractionated heparin?
Because the
What
other
heparin?
options would be fondaparinux or
How about heparin?
Sorry?
How about heparin? Why not heparin?
Yeah, that's what I'm talking about. Unfractionated heparin.
I'm sorry. I thought low molecular weight heparin. Unfractionated heparin. Okay.
Yes.
Sorry, it's my fault. I got it.
The onset of action is immediate. It has the best evidence in the PCI.
Definitely,
And
definitely.
the effect fades away within 2 or 3 hours.
I agree with that 100%. Now, if the patient come in with acute coronary syndrome and you did not put him on, you did not take him to the cath lab, you just acute coronary syndrome without stent. What do you do with antiplatelet and anticoagulation? Do you do
Acute
triple
coronary
therapy
syndrome,
or just do
acute coronary
dual
syndrome,
therapy?
and he's going to be managed medically for whatever reason.
Yeah, non-ischemia, and he's stable and fine, and he's on NOAC. What antiplatelet do you react? Dual platelet or one platelet antiplatelet?
So in this patient, we're not taking him immediately to the cath lab.
No.
So we have like 24 hours up to 72 hours to take him to the cath lab. So in
Okay.
that situation, I would hold on for the NOACs, and I would start on a low molecular weight heparin once after the effect of NOAC starts to fade down. I would go for low molecular weight heparin because it has a good evidence in non-ST elevation ACS. And if I decide to take the patient to and I keep him on aspirin also, then if I decide to take the patient to the cath lab, I would continue on low molecular weight heparin, especially if it was given within the last 6 hours before the procedure. Then I wouldn't switch to
So
heparin.
how about if you are not going to take patient to the cath lab? I mean, you decide this patient going to medical therapy. Do
So
you
it's a
do
non-ST elevation
triple
ACS,
therapy or dual therapy? Yeah,
non-ST elevation ACS with no stent.
no stent. Dual therapy or triple therapy from the beginning.
Well, it depends on the risk of thrombosis and the risk of bleeding, but ideally, if the risk of bleeding is low or acceptable, I would still keep him on triple therapy for at least a week. Because we know that even in ACS, we're planning for a conservative approach. We still need dual antiplatelet therapy because there is a ruptured plaque, most likely, and there is not just one ruptured plaque, there's a culprit plaque, and there are other plaques lurking around in other coronary vessels. So dual antiplatelet therapy would help to lower the risk of thrombotic events over the first year. So I would like to keep them on triple therapy for 1 week and then dual therapy for a variable duration of between 1 month in high bleeding risk up to 6 months in a low bleeding risk. And then we go to only NOAC for the rest of the therapy.
Okay. Just to clarify from one question here, is stent thrombosis increase more with indoxaban versus other NOAC or less?
I'm sorry, Dr. Omar, can you repeat the
Stent,
question?
stent, stent thrombosis.
Yes.
Stent thrombosis, is it more likely to be with indoxaban or other NOAC? Or the
No, if
same?
we look, I can show you the slides again. In
So
fact,
that's okay.
edoxaban was one of the medications that had a fewer MI compared to other NOACs. So if we are worried about stent thrombosis, which is a concern, then edoxaban is one of the agents that seems to be protective from stent thrombosis. I can show the slides again.
That's okay. I think we will remember it. Now, there's I don't know, Dr. Ajit is still with us here, and the question for both of you about DUAC and end-stage renal disease. What do you do? Do you use it or not? And if you use it, do you adjust the dosage? And which one do you use? Dr. Adil is still there? If you're still there, Dr. Adil, if you can unmute yourself.
Yes, I'm still here. Yeah.
Yeah, thank you so much. So, end-stage renal disease, do you use DUAC? And if you do, which one you do and the dosage?
Sorry, this is a question for me. Sorry, I had an
For
issue
both
with.
of you, for you and for Hussein, end-stage renal disease, do you use DUAC?
So my take on this question is that, first of all, as I mentioned before, our evidence comes from phase 3 clinical trials. And phase 3 clinical trials, and all of them, they excluded patients with creatinine clearance less than 30. However, based on subgroup analysis and post hoc analysis, now we can use old NOACs with creatinine clearance between 15 and 30 at a lower dose. So this is also mentioned in the guidelines. Now, patients with end-stage renal disease on hemodialysis, this is a different subgroup of patients, which was not really studied. However, we have some evidence based on pharmacokinetics and pharmacodynamics of drugs that we can use apixaban and rivaroxaban and edoxaban in this group of patients. But do we have an outcome trial? I'm not really quite sure. For dabigatran in the United States, they have 75 milligrams, which is not available in our area. They use it in this group. But overall, in patients with hemodialysis, we can use rivaroxaban 5 milligrams or 2.5 milligrams and rivaroxaban 15 milligrams. But this is based purely on pharmacokinetics and pharmacodynamics, and we don't have clinical trials on that.
I mean, part of the patients on the trial were end-stage renal disease, right? Or develop end-stage renal disease during the trial.
Well, I mean, these were excluded. It was
excluded from the beginning, yeah. But some of them, I think forgot the number, but some of them they end up with being on dialysis while on trial, and I don't remember them.
I'm
but
not
there was
aware.
no,
Yeah, I'm not aware because if they on those days, I mean, remember that phase 3 clinical trials were done like 10 years ago or something, or even more. So
right.
if they develop dialysis, they were excluded from these trials.
Yeah, I have to put that again too.
Yeah.
Anyway, thank you so much for that, Dr. Hussein. Any comment on that one?
For the dialysis patients, it's a dilemma. And as Dr. Adel said, we have only pharmacokinetic data on apixaban 2.5 right. and on rivaroxaban, but I don't think it's on the label for edoxaban. And for dabigatran, it's the 75 milligram. But these are the options that we have, considering that warfarin right. is not the best option because we know the worsening and calcification of the renal arteries, etc.
A question: patient with lung cancer on radiation therapy and chemotherapy presented with AFib. How do you treat that patient? Dr. Adil?
Yeah, so malignancy is another big topic, and obviously the one who asked the question, he wants a straightforward answer, and there is no straightforward answer in these type of scenarios. It's a multidisciplinary team. We have to involve the oncologist, because the issue with the cancer and AF, you have increased the risk of bleeding. Some of the chemotherapy might interact with the NOACs. Patients, they might have thrombocytopenia. So it is not straightforward, although it can be used in AF, but we have to discuss it with the oncologist to reach the final dose and the approach to manage these patients. So it's not straightforward, but it can be used, especially for lung cancer.
If I can, most trials of NOACs, they used to exclude patients who have a survival of less than 1 year. So we don't know. This is a situation, a patient with lung cancer and it's probably advanced. We don't have the answer from randomized controlled trials. And as Dr. Adel said, that's an individual decision that you take patient per patient.
Now, question is, the patient come in, just you mentioned it earlier, but if you can just say it again, Dr. Hussein, patient on DUAC and come in with a STEMI or non-STEMI, going for a cath lab. Do you load with Plavix and aspirin, and how much do you load?
If you look at the guidelines that were just released from the ESC in August, then right. Preloading in non-STEMI is a class 3. It's harmful. It results in more bleeding, and it does not reduce stent thrombosis. In STEMI, it's class 2B, so you may use it, but still the benefit is not marvelous. So I personally stopped preloading patients, except when it's an anterior STEMI in the emergency. But for non-STEMI, we give the second antiplatelet during the time of the PCI.
And how much do you give?
depending on the age of the
300
patient.
or 600?
For
No, patient with
clopidogrel,
STEMI. Patient with STEMI. Do you give 300 or
we
600?
usually go for ticagrelor 180. If for any reason ticagrelor is not available or there is an issue with it, then we go for clopidogrel and we go for 300.
Okay. And in addition to 300 aspirin.
Definitely.
So you load with aspirin, you load with clopidogrel or ticagrelor, which is, as you said, exactly with acute coronary syndrome is the preferred antiplatelet. And of course, patient on full dose DUAC before, and also you give full dose heparin and fractionated heparin, and you keep the INR 200 to 250, right?
Yes. Yes.
So you give all of the above. Okay.
Yeah.
And that's thank you so much, because that's I mean, as you know, I mean, everybody knows that when you start to adding on those anti-platelet anticoagulation, we become more nervous. So so this is a very interesting question to present. Is a patient with a STEMI and atrial fibrillation on full-time DUAC, you still do load of Plavix, load on aspirin, and full dose of heparin.
But in that situation, we usually go towards clopidogrel, not ticagrelor, because here the bleeding risk would outweigh the benefit from ticagrelor.
Okay, so you give clopidogrel,
Yes.
300 milligram, 300
Yes.
milligram clopidogrel, and
Yes.
300 milligram aspirin, and full dose heparin.
Yes.
Okay, great. Well, I don't think there's any more questions, and we should finish here in 3 minutes. Would like to have a kind of few final word from Dr. Hussein, and then final word from Dr. Adil. So Dr. Hussein, for if you can summarize the whole story in 30 seconds or 1 minute. Patient have AFib on DUAC and end up with acute coronary syndrome. What do you do? And the other way around, patient come in with acute coronary syndrome and down the line develop AFib. What do you do?
So we need to individualize our decisions because the situation is complicated and it has more than one aspect of bleeding and thrombosis. But the general rule is triple therapy in the beginning for a duration between 1 week and 1 month, then dual therapy until the first year, and then single therapy from the first year onwards. The agents that are associated with less myocardial infarction are edoxaban, keeping in mind that in the first 2 weeks, it's still a hazardous area. We start to see the benefit after 2 weeks, but still NOACs are associated with less bleeding compared to warfarin.
Thank you so much, Dr. Hussein. That was great. Dr. Adil, final word, 30 seconds about patient, elderly patient and anticoagulation.
So elderly group of patients are vulnerable patients, and we have seen that the risk of stroke and systemic embolism outweighs the risk of bleeding. So we should not really overestimate the risk of hemorrhage, and these patients will benefit, definitely will benefit from oral anticoagulation, provided we stick to proper clinical acumen and proper clinical assessment. And I think these drugs in the right setting of patients, regardless of the age, they have been proven to be effective and safe.
Thank you so much. That was a great summary of the talks. It was great talks, both of you. You did really well. I really learned myself. I hope that all the audience also learned. There was a lot of kind of questions and feedback from the audience. They are very happy about the presentation. Thank you so much. I greatly appreciate your time, and hopefully we'll meet sometime physically here in Dubai. Thank you
Thank you
so
very much.
much.
Thank you, Dr. Amar. Thank you, Dr. Hussein. Thank you very much. Thank you.
At the end, I'd like to thank Sajab for sponsoring this educational program, and I hope that everybody have a good evening.
Thank you.
Thank you so much.